In fact, several studies have implicated diabetes as a pre-existing condition that negatively impacts the prognosis of patients with COVID-19. However, studies are limited and the number of patients is currently small, so the reported risk for people with diabetes is inconsistent. A meta-analysis of 6 studies evaluating over 1,500 patients with cardiovascular metabolic diseases, including hypertension, cardiovascular disease, and diabetes, revealed that patients with diabetes are more likely to develop severe COVID-19 that requires intensive care following SARS-CoV-2 infection. The proportion of diabetes in severe cases requiring intensive care was about 2-fold higher than in non-severe cases. Notably, the analysis did not find that people with diabetes were more susceptible to SARS-CoV-2 infection initially. Consistent with studies in COVID-19 patients, an association between diabetes and infection has been established. Diabetes mellitus is a chronic metabolic disorder marked by sustained high blood glucose levels or hyperglycemia, resulting from impaired insulin secretion or resistance to peripheral actions of insulin. Type 1 diabetes is characterized by the loss of pancreatic islet beta cells and subsequent insulin deficiency. By contrast, in type 2 diabetes, insulin resistance occurs with associated beta cell dysfunction. Initially, insulin secretion is increased in type 2 diabetes to maintain homeostasis, but as the disease progresses, beta cells cannot meet the demand for insulin production and hyperglycemia occurs. Regardless of the type of diabetes, whether type 1 or type 2, hyperglycemia leads to macrovascular and microvascular complications that can result in increased morbidity and mortality from infections and other causes for people with diabetes. In addition to vascular disease, diabetes is associated with substantial premature death from infectious diseases, independent of several major risk factors such as smoking status and body mass index. Moreover, people with type 1 diabetes have twice the risk of those with type 2 diabetes for infection-related death. This association has been observed clinically and linked to potential causal pathways, including an impaired immune response within the hyperglycemic environment and manifestations of diabetes such as neuropathy. It's widely accepted that diabetes leads to an increased susceptibility to infection. However, conflicting data suggests that diabetes-associated comorbidities contribute to the observed phenotypes, and the exact mechanism by which the diabetes disease state leads to this predisposition remains unclear. Diabetes has been associated with hyperglycemia-related events of the immune response. These include a reduced response of T cells and neutrophil function, as well as disorders of humoral immunity. Furthermore, the hypoglycemic environment can increase the virulence of some pathogens. Diabetic complications, including vascular insufficiency, sensory peripheral neuropathy, autonomic neuropathy, and increased skin and mucosal colonization, can predispose people with diabetes to microbial infections. Once an infection is established in someone with diabetes, the infection can provoke further diabetic complications such as hypoglycemia, hyperglycemia, and ketoacidosis. Infection leads to an increase in insulin counter-regulatory hormones such as catecholamines, causing insulin resistance. Additionally, the release of pro-inflammatory cytokines interferes with normal insulin signal transduction and also contributes to insulin resistance. Importantly, people with type 1 and type 2 diabetes are at increased risk for developing lower respiratory tract infections. As such, medical appointments for respiratory tract infections are more frequent for patients with diabetes compared to those without diabetes. Respiratory infections caused by Streptococcus pneumoniae and influenza virus are the most commonly observed in the diabetic population. In fact, during influenza epidemics, people with diabetes are 6 times more likely to need hospitalization than those without diabetes. Furthermore, people with diabetes are at greater risk of dying from pneumonia, and diabetes is associated with a poorer outcome for community-acquired pneumonia. Structural and functional abnormalities adversely affect microbial clearance mechanisms within the lungs, resulting in a higher risk of infection and poorer outcomes for patients with diabetes. For example, accelerated decline in lung function occurs in people with type 1 and type 2 diabetes, especially when hyperglycemia is present. Lungs in patients with diabetes can show anatomical changes, including micro and macroangiopathy and narrowing of the alveolar space. Among patients with diabetes, pulmonary autonomic neuropathy is quite common and affects control of ventilation. This can lead to a reduced bronchial reactivity with diminished bronchodilation, further altering lung function. Consistent with observations around diabetes and respiratory infections, an early prospective study of SARS patients correlated the presence of diabetes with adverse clinical outcomes. 115 patients diagnosed with SARS were studied for short-term outcomes. Adverse outcomes were defined as the need for mechanical ventilation or death. The presence of diabetes was associated with an increased mortality risk of 4.7, while the presence of diabetes and or cardiac disease was associated with an increased mortality risk of 12.5. Comorbidities in this group were also shown to be significant in affecting adverse outcomes. Another study demonstrated that a history of diabetes and ambient hyperglycemia were independent predictors of death and mortality in patients with SARS. Clinical and biochemical characteristics were compared for 135 patients who had died from SARS versus 385 survivors. A history of diabetes among the deceased group was much higher than in the survivors, 21.5% versus 3.9%. Independent predictors for mortality included a history of diabetes and hyperglycemia before steroid treatment. Furthermore, fasting plasma glucose was independently associated with an increased risk of mortality, with the hazard ratio increasing 1.08-fold for every 1 millimole per liter increase in fasting plasma glucose.